thank you all the speakers. They have displayed the excellent experience. We are very much enriched with all the cases you have displayed. At the same time, I also thank Dr. Aniruddha De, our chairman scientific session, to put such a session, excellent session, which probably I have not seen before. So let us come to our discussion part. So it is open to the forum. If any question, then I will summarize the cases. So if there is any question regarding any speakers, any topics.
So in the first case, one question from in the chat box is there. Dr. from Samugasundaram. He commented that mid part of the to Dr. B. N. Jha, mid part of the atrial septum could have been exercised and patch closures should have been done in the second city. What is your comment about Dr. Jha?
His question is for
Dr. B. N. Jha.
Dr. Jha. Regarding recurrence atrial myxoma.
Dr. Samugasundaram has questioned it.
Dr. Jha.
Yes, yes. Am I audible?
Yeah. He said mid part of the atrial septum could have been exercised and patch closures should have been done in the second city.
Because that is the area of attachment.
Yeah, area of attachment.
It is a pedunculated mass. So all time the surgeon remove the mass but keeping the seed intact. So his question is rightly addressed, whether it should be uprooted by excising the atrial septum.
Second time, when 2007, first time it was been done, the same surgeon did the second surgery. And in that time, according to him, he did the extensive resection, but double patch reconstruction is now one option in some center. I think that is one suggestion, but basically extensive resection was done the best by the surgeon, consult the patient. He also consulted us, and together all three of us, patient, myself and my surgeon, and with due of their best care, he assured that we'll do the best part we can resect so that it should not recur. But it was also surprising for the surgeon also, that third time it reoccurs.
Another question, Dr. Jha. Yeah, many times the recurrent CBA is due to the tumor embolization.
Yes, sir.
And
yes.
how far the anticoagulation prevent this embolization is yet to convince, because you have put this medical therapy as a last line to tackle this case. So this remains a question of debate, whether the
together warfarin and antiplatelet ecosprin together we are keeping the patient 7 years. Initially 150 milligram and 5 milligram, and gradually 1-2 times we got some bleeding, particularly in the local, so we reduced 3 milligram warfarin and 75 milligram ecosprin. This way we are maintaining last 7 years. And others,
it is good for the patient, but it is very difficult to
how
it prevents tumor embolization.
Yes, sir. Yeah. One thing is that this tumor, once in 14, it was size in 3.5, gradually 4, but now it restricted almost last 3-4 years. Size is not increasing. It is up to around 4.8 something. Sir.
Probably this is the natural history of the myxoma. With the aging, there is a spontaneous tumor lysis or tumor halt in the tumor progression.
Yes,
because
sir.
basically it is a tumor of the middle age, and so with the aging, probably it automatically halts.
The three more questions is there. One to Dr. Parasar. Dr. Samugasundaram has commented. Dr. Parasar, your case should have be better called as mid-cavity obstruction rather than LVOT obstruction. Dr. Parasar,
sir. Once this mid-cavity came a bit later on when we were doing the echo or so, this mid-cavity, or which is usually beyond slightly the papillary muscle, it can be mid-cavity or so, it was only detected at when was a frame by frame analysis was done. So because we have not seen too many of the cases of a papillary muscle abutting against the septum. When you see a mid-cavity obstruction, it is usually the muscles of the inferior wall and the septum which completely come and obstruct the left ventricular mid cavity. But here it was mainly the papillary muscle. I agree it is not the LVOT, because which I showed in a later images that it was mainly the papillary muscle which was producing, and it was also shown in the sub. So this may be a variety of a hypertrophic obstructive cardiomyopathy which can be at the LVOT level or at a mid cavity level, but it was only the mechanism which was only seen when we could see by a frame by frame analysis, and rather than one of our colleagues suddenly said it is a diastolic LVOT obstruction, but when we took a Doppler, it was a systolic phenomenon. So he's already, it is not the LVOT obstruction, because the LVOT is mainly caused either, if you see the paper from the Mayo Clinic, they said LVOT can also be caused by a massive hypertrophy of the basal septum. And normally the cause is a hookah with the SAM, but the SAM was not present in this case. So definitely it is one of the obstructive varieties in which it is slightly more at the papillary muscle level. That is agreed also. So,
Yes,
but
sir. I
only
fully
point was
agree.
that how was it? Could it be an acute phenomenon? No, because such a massive sort of a abnormality could have been missed for the last about 10-12 years or so. It could not have developed overnight or so. So that is the sort of a mystery in this case for the presentation also, and leading cardiac centers.
Sir, this was a this was a case of rheumatic mitral stenosis. No
Yes.
evidence of congenital mitral stenosis.
No, it was a rheumatic, because
Because
the patient gave a very classical history of a rheumatic fever in 1992. She had a classical history of a rheumatic fever and a rheumatic arthritis. So there was no reason of a congenital, and there are different varieties of a congenital mitral stenosis. It was a classical history in a 36-year-old lady with a history of a rheumatic arthritis in 1992, not a congenital one.
Yes, sir. I fully agree that whenever there is a LVOT obstruction, there should be a SAM, and absence of SAM indicates that it is not obstruction at the LVOT level.
At the
So
LVOT.
that is very, very unusual mechanism that probably we commonly we have not in mind. So probably we have missed. Probably many observers have missed.
Next question is what is the to Dr. Devika Chatterjee, what is the impact of mitral stenosis on hemodynamics of L kappa and its symptoms?
Yeah, see, if there is pulmonary hypertension along with the mitral stenosis, then in that case, the blood flows from the pulmonary artery to the left coronary artery, even if there is no collateral. So the symptoms of mitral stenosis may be, may remain silent because of the raised pulmonary hypertension in presence of mitral stenosis if there is L kappa.
Yeah,
Madam, lot of L kappa patients present with dilated cardiomyopathy in the young. How was the ejection fraction in your case? LV function?
Yes, in this particular patient, LV systolic function was absolutely normal. There was no finding of ischemia like we get the endocardial fibrosis or papillary muscle fibrosis scarring. Nothing was there. This lady, she sustained all the injuries even at rest and with exercise. There was no finding of systolic dysfunction, no regional wall motion abnormality.
So that is the probably most unusual thing, because L kappa should have been symptomatic before the symptoms of mitral stenosis develops. Should have symptomatic, either in the form of chest pain or in the form of LV dysfunction or some abnormal ECG.
Yes, that is
abnormally, there should be abnormal ECG.
Yes, this case was reported from our hospital. It was a very, very unusual presentation.
Yes.
This girl was going from hospital to hospital with diagnosis of mitral stenosis. Then ultimately she came to us because of her shortness of breath. You know, the mitral stenosis was not so significant. The valve area was 1.2 with a mean gradient of 5 millimeter of mercury. But
It is
still
practically
was,
negligible, mild.
yes,
According to
Maybe
him,
mitral
it is
stenosis
mild.
is protecting that L kappa symptoms because LVDP was not rising because of mitral stenosis.
yes, but that happens in presence of pulmonary hypertension. So it was not there, but then patient didn't have, the patient had the shortness of breath. So that is why.
Shortness of breath may be due to the rise of left atrial pressure and increased pulmonary venous congestion, but LVEDP was not rising. LV function was preserved maybe due to this mitral stenosis that was preventing the dilatation of the left.
Yes, that was covering up the symptoms.
Yeah.
Yes.
Now the question answer. I think the time is up, so it's better to wrap up this case. To conclude the session, Chairman is asked to conclude the session. Please, sir.
Yes. Thank you. Thank you to all the
Thank
speakers.
you.
Thank you all the
Thank you
speakers.
for having me in this session.
And thank you, our scientific chairman. So let us close the session.